So I'm Andy Hadley. I'm solution architect for the Dorset Care Record and also Wessex Care Records. And I'm going to talk a bit about our progress. I called it Pilgrim's Progress. It kind of feels like we're on a very long journey, and it's really interesting listening to Jim and the experience in the north of Scotland, because actually we have all the same challenges. We're just solving different bits of the same puzzle as we go forwards, and hopefully we'll all get to a full jigsaw at some point. But I think it will be a continuing journey. We've been at this for less time than some of the other participants in the room, but I think partly because in ICS our management team are very keen that we progress quickly, and so there's been a lot of scrutiny about, well, how are we doing, how are we getting this thing forward, how are we making it happen, at the same time as all the organisations are under enormous pressure to deliver their internal agenda. I saw, I don't really do LinkedIn very much, but I saw our LinkedIn this from one of our clinical leads, Anna Coslett, who is a clinical leader on the project and spends a lot of her Monday mornings with the team struggling through all the difficulties that we face. And she'd heard some news from a consultant in the A&E department that said some information that you'd put on the record that was shared by the Dorset Care Record, I saw, and it saved this patient's life. And she was really impressed by that, and so was I. You know, it's kind of the sort of thing that you feel, actually, this really is all worth it. With that in mind, you know, it spurs you forwards through some of the difficult areas, which we'll talk about a little bit possibly. But I'm going to pass you over to Matt now. He's going to talk a bit about some of the project.
Perfect, thanks for that. And absolutely, it's really important to get that. This is the reason we're doing these programmes. It is to make that clinical difference. That's absolutely critical. So what are we doing down in Dorset? So it's a shared portal, access data sets across health and social care. That's really important. Healthcare, I wouldn't say easy, but healthcare has its own challenges. Bringing social care into that mix, a number of you will understand, that really does bring its own difficulties as well. And that's something we're certainly working through down in Dorset on the care record there. Giving single data repository for professionals to support the safety effectiveness of care. That's really what the core purpose is. But it's not just that. It's also then about giving citizens access into this. A number of people are struggling with that same piece or on that same journey. That really does bring some additional challenges. And then building pathways. And certainly as you start to build those together, how does the citizen contribute that to their pathway? Are they just there to look up data, see their record, or are they actually implementing information into that? Are they taking photos, or are they actively participating? How can you start to change the way care is delivered through that functionality and engaging with the citizen in a different way? And those are some of the things we really are starting to work and grapple with down in Dorset. In terms of the current status, nearly 900 registered live users, which is great, nearly 2,000 logons, 2,500 records accessed in the last month, so the usage is there. It will start to grow. There's a couple of key things that we see that really are going to start to grow that. But in terms of records, nearly 1.5 million individual patient records in the systems. There's a lot of data in there starting to grow. All the GPs are signed up, so we're getting all the data feeds in from there. And all the secondary health partners as well. So there's a lot of core information coming in, but there's some things we need to do to really grow that usage statistics. That's just about 15% in terms of the live users of where we want to get to in this initial first phase. We've got an ever-increasing number of data feeds. That becomes really critical. I'll talk a bit about that. And we've got a really good structured process now for how we work through the design, build, test, deployment across all the multiple partners and across Orion, because putting that all together into a clear program where everyone understands what they're doing at any one time, where the environments are available to support what people are doing at any one time, there's real complexity there when you've got different priorities in different parts and organisations. So there's a lot to coordinate and keep in check. I really wanted then to share some of the key challenges. This isn't about focusing on the negative bits, but it's about, this is the reality of putting in this kind of capability across a health economy. And it's really important that we start to understand what some of those are. Governance is a real difficulty for us. How do we get effective line of sight into what we're doing at all levels of organisations? And how do we get effective decision making across those organisations? How do you end up with a board that can make decisions that are then enacted on within the individual organisations? That's been a real challenge. Decisions are made. Are the individual partner organisations then delivering against those decisions? Well, in all honesty, not in every case. Part of that's to do with empowerment, but there are other reasons as well. Those are some real things that need to be grappled with in order to get an effective programme where the delivery is driving. The capacity is another thing that we really do need to work on. I think it's fair to say at the beginning of the Dorset Care Record programme, there's a real underestimation done within the partner organisations of what it was actually going to take in order to feed the information through into the Orion system. A lot of the complexities around, and it comes into the data consistency as well, but a lot of the complexities around providing the right data sets, getting that out of source systems that hold the same data but in different formats, different tables, different information, making sure that's provided. There's been some real challenges in doing that. I think the partner organisations thought they would find that easy, and the honest answer is they haven't. And there's a lot of support and work that the programme's doing to help on that and to drive that forwards, and we are making a lot of progress. But if you're on this journey, don't underestimate it. Capacity and competing requirements, that's always a problem. But I think where we're bringing shared care together, so care or information for programmes that are across a health economy, it's much easier for individual organisations to deprioritise that. Strategically, it's of massive importance. But within an individual organisation, today's priorities may, today's pressures rather, may take more priority. So grappling with that problem is really important as well. I've talked a bit about data consistency. Data structure in source systems, yes, absolutely, that's an issue. But picking up on the difference between health and social care, just that different language, different terminology, it exists across all organisations, as we know, but I think when you bring social care and healthcare together, that really grows as an issue that needs to be grappled with. And that's certainly one of the key things we're finding, just to the level of what do you call your information governance process? Do you have a clinical lead in social care? Things like that become a real issue for us to work through. And then the final part really is, what is the risk appetite of the organisations and of the programme? Everyone wants perfection. Everyone can see where the issues are in the current processes, what they want to do better, how they can make a difference. And that's brilliant, but sometimes getting there is really, really hard and involves huge change within the organisations and potentially huge change and huge configuration effort within the system as well to achieve that. And actually sometimes you can chase for that and stop yourself from getting to a lot better in meaningful time frames. And so balancing that and understanding where we can get to now, where we want to get to tomorrow, where we want to get to the day after, and going on that journey rather than shooting for the final stage immediately can really delay delivery. And so that's one of the other parts that we're grappling with. And just governance, consent, the processes around that, again, particularly in social care, just the ability to share data into the system of core demographic information. We'll talk a bit more about some of the successes on that. But there's a lot of concern in social care about sensitive data, as you'd expect. There's a couple of ways of grappling with that. One is just where a data is potentially sensitive, don't send it into the record. We've actually taken a different approach, which is how do we send the right amount of data in, picking back on the point earlier. But again, there's been some real challenges with that. In terms of successes, though, it's not all about the challenges. So bringing social care into the record, we have pretty much dealt with those challenges. We've got a clear plan. That's the next set of data that's coming in. We understand how to manage sensitivity, and that will give us that comprehensive data set across health and social care in Dorset. That's key focus now on the next stage. We expect that to be coming very, very soon. In addition to that, bringing more data into the record, really focusing on documentation, ADTs, and then additional departmental feeds, but really growing the value of the information that's in there, allowing the statement that Andy was talking about earlier that Anna Kosler, our clinical lead, made, that should become normal, that's the benefit of this. And the more data we get in, the more value we get. Single sign-on with context, that's critical. That gets you the usage of the solution up to a much higher level where people don't have to go in and search for a patient just within their core systems, press the link, the information comes up. That's a key drive for us. A lot more work to be done on care pathways so that we can really start to drive the workflow that's in there. We talk, maternity is the initial focus, and that is now live technically, and user go live going in the next month. But we've got lots of other use cases that we're looking at and working around how we can start to build and grow that capability. Citizens Portal, absolutely, that's critical when we start to bring that functionality into it. That really becomes full ecosystem. I'll hand you back over to Andy at this point.
Thank you. I thought it might be useful to just talk through a few issues that might be relevant particularly to other people. And the first one of these was just around our GP data. And again, Jim mentioned the difficulties in Scotland, which I know are common for all of us, but we've actually got to the place where we've finally got all of our 84 practices agreeing to share information in Dorset. And that's been a difficult journey, but quite an accelerated one, given we only went live February of last year. This is the MIG. This is live access to our GPs. It's the way in which we get the data. And I should have put the most recent at the bottom, so it's most recent at the top. You can't see it. The blue is successful access, so you can see that's on an increasing trajectory. The orange are interesting because those are patients where they press the button to access the GP information, but the GP practice was in Hampshire. So they're our immediate neighbours. That's part of our work we'd love to do with Hampshire and the Isle of Wight as part of our LACRA work to actually link across that boundary. So that's about 2% of the accesses. And of course, once you as an ED consultant, they're probably mostly Bournemouth Hospital, an ED consultant in Bournemouth, once you've clicked and got no success, you're less likely to click. So that's probably like to be a way underestimate of the demand from that end of the patch. The grey ones are other failures, and sad to see that up this month and trying to find out exactly what is at the bottom of that. But that includes a few who are in military establishments, so they're under the military primary care services. I mentioned that at a meeting about a month ago, and somebody in the audience said, "Oh, I'm working with the military services. I'll put you in touch." And I heard nothing, but I actually just heard from yesterday and have made the link to try and work out what are they actually doing, how are they planning to link with the NHS, because under the military covenant we're supposed to be dealing particularly with serving and veterans and their families in just the same way, and we're not. We don't have that information to hand. There's also information obviously from elsewhere in the country, and again that's part of the LACRA record, but the really interesting bit I suppose in terms of Orion and the work with Scotland is, well, we do get visitors sometimes come south of the border. You know, how do we make sure that people are treated across the home nations? And again, there's national work which we're linked to in terms of trying to achieve that. So although they're a small number, the failures are actually quite interesting to me in terms of how can we reduce those, how can we, and how much frustration every time someone's clicking the button and something's appearing on that graph. It's a real patient interaction that's failing to be served today. Matt mentioned sensitivity, and this has been at the heart really of the concerns in our local authorities about how they share information with us and across the patch, but also for mental health services and our community mental health provider. And the three main areas are witness protection, children going through the adoption process, and people going through gender reassignment. And these are really sensitive areas. They're very small numbers, and as Matt said, worrying about these too much and it means you don't move forward on the wider piece, and that's where we've been. But our clinicians were telling us very actively that actually a lot of these people do have very significant health needs, and actually just to exclude them from the record is probably disenfranchising them from the care that we would like to give them. So we've got to find the right way to handle that. As we went through it, we found across the county we had really variable ways in which we deal with sensitive patients. So in one of our organisations, one of our local authorities, they put them on a special caseload. Well, they know the special caseload means they're a sensitive patient, but nobody else would. So as you share the information, some of those intricacies and differences in the way people operate become exposed and are actually not safe. So we're having to look at how we do that across the board. We had quite a discussion about using the national sensitive flag from the spine, and again, and I know that some other places have the same problem, that not all the hospitals have a live feed from the PDS. They do the NHS number tracing in batch. And of course, that's the time when you're most likely to want to look at other people's records to find out what has happened with this person that I'm just about to deal with in other care settings is on admission, and very often that's before you've done the match. So the time when they want to access the shared care records or access the primary care records is the time when they're least likely to have the NHS number. But that also means they've not got access to the national spine sensitivity flag, and they're also not dealing with sensitivity in the appropriate way. We found we've actually got about, so initially we were told there were only about 80 patients in the county of Dorset that are sensitive, and particularly around those at the top two of those categories. They're now talking about 8,000. And that's a real worry to us, and that's also a real worry to the national back office, because they can handle about 2,000 a month nationally. And so if we go to them and say, here, we've got 8,000 records, can you just mark these as sensitive? Because it's a very manual process on the spine. So we're talking with them, and part of that was actually, actually the way the NHS are using the national sensitivity flag is not the way that they thought when they designed it that we would be. And what we're talking about now is what they were kind of expecting in the first place. So we find ourselves, it feels like we're beating our head against a brick wall. We're actually doing what would be the right thing by these patients, trying to make sure that information is available, that if necessary their address is suppressed, and I'd like to see the portal having a very clear indicator, say all of your patient information is really sensitive, but this one is particularly so. But working with the national teams and the access that we have to be able to solve that problem properly is moving us forward. And as Matt said, we've been doing the hard graft to make that happen, but I think we're now getting to a better place on that. Another element for our community provider is the way in which they set up TPP System 1, a system that everyone loves to link to, is that they set it up in a very complicated way. That each service was given the chance to create the data tables that they wanted. So the configuration is really complicated. So every time we try to get the information out in a structured way into the shared record, they got so far and went, oh, this is a bit difficult, can't actually make this work. So we spent months and months doing that. What we've got to now is using the GP Connect mechanism, and this is in our test system, to at least get an unstructured view of the community information. And again, this bit about getting some progress moving forwards, actually getting the value out of it, it's not perfect. We've been trying for a long time to get GP Connect and to get to structured GP Connect, but this at least allows us to get that information into the shared space and available, and that's something to celebrate. Now, the next speaker is from Orion and is talking about medicines, and something that we've been talking with them about and it's actually in the very first presentation this morning, taking you back, Gary mentioned the interopen work and particularly the Connectathon in Leeds. I was involved probably as the idiot user on the interopen board until quite recently to try and sort of promote the idea that we need to use standards to get these things working across different places. So I'm passionate about getting this stuff working. And we've been talking with JSC, now called WellSky, and with TPP and with Orion about using the Orion portal to provide that glue at the centre to enable you to get a single view of medications in a structured way across all care settings. And it kind of started with our community hospitals saying we don't have doctors in the hospital on the weekend. We want to continue with a medication that was given to us by the acute hospital when they discharge the patient on a Friday afternoon until the Monday, until the GP can pick it up. As we moved to EPMA solutions rather than paper strips flying around the system, that was becoming more difficult. So they were trying to get integration between JSC to JSC, and I said, you're solving the wrong problem. The real problem is that your junior doctors in in A&E and in your admissions units are retranscribing information that's known in primary care. You really need to get that in. So the key for me is to get the GP record in a structured way through to EPMA, but also with other information that we know. And another key gap in our system, and Bristol have done some really good work using the Orion portal and the FHIR profiles to do it with their drug and alcohol service. So we're not yet there. We're sort of talking about it and working with them and talking with Aaron, who's going to talk to you next from Orion, around how do we get that consolidated record. And again, the Glasgow board, I've heard them speak before around the great work they've done in terms of creating that single view. Our secondary care clinicians will do their reconciliation within their EPMA product, so we've got to get the information back into the EPMA to do that. And we don't have the benefit of the Sky approach in terms of making the GP information easily available. So that's work to be done, but work that we're actively talking to do. And I'll finish with, and I'm sorry, this is probably a bit small to be seen, but this is one of our renal consultants. I had a conversation socially with a renal specialist nurse who said, DCR, you're involved in that, aren't you? Yeah. It's revolutionised my work. It's completely changed my work, which was just amazing to hear. But this is her consultant who, we have a county-wide service based in the west of the county in Dorchester. But he works, interestingly, out of a shed. It's not the hospital, it's on an industrial park where we give the blood dialysis in the east of the county. Again, he finds the shared record, the access to information from across the patch really useful because obviously patients don't always know exactly what their condition is or what the latest results are or how to do it. So again, a happy user, which we love to see. Thank you very much.